Hey everyone, welcome back to the surgical and procedural phase of our masterclass. I'm your host, Harshal. We've spent a lot of time mapping out the shoulder's architecture, but today we're taking a massive leap. We're stepping out of textbook anatomy and right into the operating room, and honestly, into the high-stakes world of medical billing. Time to put on our detective hats and protect that practice revenue. For this explainer, we're transitioning into the highly regulated world of procedural coding. We'll do a lightning-fast anatomy recap, define what a shoulder arthroscopy actually is, and then dive deep into those strict diagnostic guidelines and bundling rules. Finally, we're going to test your skills with some real-world coding scenarios. All right, let's jump right in. But first, let's ground ourselves, because as we all know, you literally cannot code what you don't anatomically understand. In parts 1 through 3, we mapped out the intersecting bones, the 4 distinct joints, especially that glenohumeral joint, and of course the 4 sits muscles of the rotator cuff. Just keep this anatomical blueprint in the back of your mind. It's going to be your absolute best friend when you're trying to decipher a surgeon's complex operative report. Okay, so with the anatomy fresh, how do surgeons actually get inside the joint to fix things without making a massive, traumatic incision? Well, that's where shoulder arthroscopy comes in. Think of it as a highly precise, minimally invasive spy mission. Instead of filleting the shoulder open, the surgeon slides an arthroscope, basically a tiny high-tech camera, through a very small portal incision. This lets them see the entire joint on a monitor in real time. Just look at the precision here. The entry angle of the scope gives the surgeon this beautifully clear, magnified view of the intra-articular structures. You can easily spot the labrum, the cartilage, the tendons, all without the massive tissue trauma of a traditional open surgery. It's an absolute game changer for patient recovery. Now, from a coding perspective, why are we doing this? A surgeon will usually recommend this procedure to evaluate instability or labral tears, or maybe to fix rotator cuff and biceps tendon tears. It's also super effective for treating frozen shoulder, clearing out loose bodies, or even debriding an infection. Basically, the arthroscope is the ultimate versatile tool. So, how do we actually code this? The crucial first step is understanding the foundational exploratory work, the diagnostic arthroscopy. Our absolute baseline code here is CPT 298005. The official descriptor covers a diagnostic shoulder arthroscopy, which might or might not include a synovial biopsy. But look closely at the language. It's designated as a separate procedure. In the coding world, that phrase is a massive red flag. It's telling you this procedure is almost always just a small piece of a much larger puzzle. We'll unpack that trap in just a second. If we break the surgical technique down into coding steps, it's really systematic. First, the scope goes in via the portal incisions. Second, the surgeon systematically inspects the labrum, biceps anchor, and articular cartilage. And finally, step 3 is an optional synovial biopsy for pathology. Whether they actually take that biopsy or just look around, the whole thing still maps right back to 29805. Now, let's get into the most critical part of this explainer, the golden rules of arthroscopy coding. These are the definitive guidelines that keep auditors happy, get your claims approved, and prevent those super frustrating payer denials. Rule number 1, you have to clearly distinguish between diagnostic and surgical work. A diagnostic arthroscopy is purely visual inspection, plus maybe that optional biopsy. It's just finding out what's wrong. Surgical, or therapeutic arthroscopy, on the other hand, means a definitive intervention actually happened at the joint, like repairing a tear or shaving down bone. And that brings us to rule number 2. If you only remember one thing today, make it this: the strict inclusion rule. Surgical arthroscopy always includes diagnostic arthroscopy of the same shoulder. You can never, ever bill a diagnostic code separately if a therapeutic procedure is performed in the same session, on the same shoulder. The diagnostic peak is already baked right into the therapeutic fix. Building on that bundle logic, don't try to bypass NCCI edits by slapping a modifier 59 on open and arthroscopic work done in the exact same anatomic location just to get an extra code paid. The guidelines completely forbid this. But, and this is a really important caveat, if an arthroscopy is done along with a separate, distinct open arthrotomy, you can report the appropriate code, but you absolutely must append modifier 51 to show they are multiple distinct procedures. Which perfectly segues into our next rule. What happens if an arthroscopic procedure goes south and the surgeon has to immediately convert to an open surgery? Well, in that scenario, you only report the open code. Do not build a scope. Instead, you append modifier 22 to the open procedure code. That modifier 22 tells the payer, hey, this was extra complex, took more time, and includes the prior diagnostic scope work the surgeon did before having to open the shoulder. All right, let's put on our coder's shoes and actually test these golden rules with some interactive scenarios. Let's see how this logic holds up in practice. Here's scenario 1. Imagine your surgeon does a diagnostic scope with a synovial biopsy on the right shoulder. While in there, they spot a full thickness tear and immediately perform an arthroscopic rotator cuff repair during the exact same session. Think about what we just covered. How are we coding this? If you said bundle it, you hit the nail on the head. Because of our inclusion rule, you report only the surgical repair code. So that's 29827 for the rotator cuff repair, plus the RT modifier for the right side. That diagnostic scope, CPT 29805, is considered an integral part of the surgery, so it essentially drops off the claim straight into the shredder. Let's try another one, pulled straight from the deepest coding guidelines. How would you code an anterior labral repair alongside the removal of a loose body? Now, crucially, the operative note explicitly states the loose body was greater than 5 millimeters. What codes are we pulling? For this one, you'd report both CPT 29806 for the labral repair and CPT 29819 for the loose body removal. Why? Because that size threshold, greater than 0.5 centimeters or 5 millimeters, is explicitly documented. If it was smaller, or if the surgeon just forgot to write down the size, an auditor would strip that loose body code right off your claim in a heartbeat. Awesome job navigating these complex procedural guidelines today. It's a lot of dense logic, I know, but mastering these basics is going to make the advanced codes we cover later in the series so much easier to digest. Let's quickly recap our core principles. Diagnostic scopes are strictly bundled into surgical scopes. Never build them together for the same shoulder. If an arthroscopy converts to an open surgery mid-session, drop the scope and apply modifier 22 to your open code. Loose bodies have to be documented as greater than 0.5 centimeters to report separately. And don't forget modifier 51 for those concurrent open arthrotomies. Remember, compliance is your absolute best defense. In our next explainer, we're going to dive into the fascinating and honestly highly confusing concept of the glenoid clock face to master CPT 29806. But before we wrap up, ponder this. If a surgeon documents repairing a slap tear at the 12 o'clock position, how does that drastically shift your entire coding strategy compared to a repair at the 4 o'clock position? We'll solve that exact puzzle next time. Until then, decode healthcare with Harshal.